I'm here on behalf of our research team. I'm usually part of a duo. I'm a radiation oncologist, and the other part of my duo is Lawrence Port, who's a radiation physicist, and we typically travel in tandem, and he sends his regrets. Today I'm going to talk, as Mira mentioned, about automated radiation treatment planning for low and middle income countries. And as she mentioned, the two of us were here in Mwanza 2 years ago, where we gave a talk that had a lot of ideas and not a lot of data. And it's been a lot of work from them until now, but we're excited about how far we've come and where we're going to go next. Despite the fact that Lawrence and I typically travel together, that doesn't include the huge research team we have behind us. Lawrence is at MD Anderson, and I moved to Stanford about a year ago, but we have a huge number of radiation physicists, graduate students, and team members throughout the world. Our major partners are in South Africa and in Manila, in the Philippines, and we also would be nowhere without our commercial partners, most notably Varian Medical Systems as well, that has served as a real backbone to this work. So as we've talked about extensively over the last 3 days, radiation therapy is crucial for cancer care throughout the world, and it's estimated to be needed in at least 50% of patients newly diagnosed with cancer. But as many people, including Dr. Henke and Dr. Awusa mentioned, not only can we treat patients with curative intent, but palliation is very important when patients are presenting with advanced stage disease. And one of the most cost-effective ways of providing palliative care is the use of radiation therapy. So what we need to do is get high-quality radiation therapy to as many places in the world as we can. But the problem is that radiation, as we know, is complex, it's technologically advanced, and we require not only equipment, but training and quality assurance at multiple steps. So these are maps and diagrams we've seen earlier in the during this conference, showing not only the shortage of radiation therapy units, but the shortage of trained staff that many centers and many partnerships are attempting to address, including Dr. Avery's work to train medical physicists throughout the world. But as noted, there are a lot of steps in radiation planning and delivery. I, as a physician, need to diagnose a patient and determine that radiation therapy is necessary. I need to move forward with radiation treatment planning, and oftentimes my team is waiting on me to delineate what I want to treat and what needs to happen. Once I finalize this, it then goes to the treatment team comprised of radiation physicists, dosimetrists, or radiographers, where they can choose beam arrangements, calculate doses, and provide an iterative plan to me as the radiation oncologist to review. But then oftentimes it needs to start over. Is that the best plan for this patient? Can we accomplish it? Has the tumor grown in the interim? And this goes back and forth. So even when we diagnose patients, even when we identify they need radiation, oftentimes there's a huge delay in starting treatment because of the needs of radiation therapy to provide good plans that are appropriate to patients, treat their disease, and minimize side effects. So there are a lot of steps needed and a lot of people needed between the diagnosis and the treatment with radiation. Now, our goal is to create a system that helps with this. So while we are trying with industrial partners to get new equipment, high quality equipment, robust equipment throughout the world, and there are many centers, including work that Dr. Avery mentioned, to train staff throughout the world, we all can make changes and we can all make this process more efficient. So we wish to do this with some computer technology. So we want to create a system that we've called the Radiation Planning Assistant that can create automatically high-quality radiation treatment plans. And at the beginning, we focused on the cancers that are most common and most curable with radiation therapy. So several of the talks about cancers in the individual countries have highlighted the need for cancer treatments for cervical cancer, breast cancer, and head and neck cancer. And these are the three that we focused on. We want to be able to push a button and create a treatment plan that is created from scratch. All we need is a CT scan coming in, transferred from the local machine, that can create a plan in less than 30 minutes. that is compatible with all treatment units and record and verify systems. We don't want to create a system that requires you to buy a specific machine or have a new machine or a specific brand of software in order to make it use. And we want to include internal quality assurance in an automated fashion with each step to ensure that what is coming out and to treat a patient is of high quality and functionally will not hurt them. We want to limit the need for the radiation oncologist because oftentimes the physician is the rate limiting step. So getting those contours to physics oftentimes is the problem. So we want to limit the need for the doctor to delineate the target because they are the person that has examined the patient and reviewed the scans. Provide the radiation prescription, know what needs to be treated and to what dose, and then to approve the final plan. And then finally, to create an electronic system that can be used by a trained individual with a high school education and a half a day of training on the system itself. And oftentimes this causes some concern. What about all of the people that we're training as radiation therapists or radiographers, as dosimetrists, as physicists? What are we going to do with those jobs? But the truth of the matter is we still need those jobs. We are asking the system to take the place of a lot of hard work that takes a lot of time so that each of those people can then work at their highest scope of practice, so that the radiographers can treat the patients and get more throughput every day, so that the radiation physicists can, in fact, do machine quality assurance, can commission machines, can provide the quality assurance that is needed to make sure that we get more and more patients through, and so that the physician could diagnose, treat, and care for more patients. So this is the way the system works. And this is pretty much all we had 2 years ago was a plan and not a whole lot else. So what we hope to do is take a CT or 2D simulation and a physician treatment planning order, so a delineation of what should be treated and to what dose, and then it goes into the system. Internally in this computer software, everything else is taken care of. The CT tables removed, body contour, isocenter, there's atlas-based contouring of targets and normal tissues. It creates fields, optimizes the dose, it calculates it, does a second verification simultaneously using different techniques, makes sure that they agree, and if so, gives you a plan for the physician in less than 30 minutes. And that plan can then be reviewed by the physician. Does it work? Is it an appropriate plan? If so, it can be transferred to the record and verify, and we can move forward with treatment. If not, it will go back to manual planning within the physicist or radiographer workflow as it is done right now. So that was our goal. So overall, we've actually been able to move forward on all 3 treatment sites that we've intended. For cervical cancer, we've been able to create a system that allows auto delineation of field arrangement to create a 4-field box and optimization of beam weights. In head and neck, we decided that really for a lot of the new centers that are getting VMAT capable machines, the most effective treatment is going to be VMAT with the lowest toxicity. So we've created a system that auto contours normal tissues, targets, and creates a VMAT plan. And then we are currently finalizing breast and chest wall treatment. That currently is work in progress, where we auto contour the normal tissues, the volumes, determine fields, and develop a field and field arrangement. All of this can happen for each case in less than 30 minutes. So to talk about cervical cancer, the first thing that we start with is a patient CT. That is the only thing that is necessary to start this process for cervical cancer. In the system, so behind the scenes after a CT is sent in, the bony anatomy is identified, it's projected onto a beam's eye view, and based on the beam's eye view and bony landmarks, a 4-field box field arrangement is set up. So we've been able in less than 30 minutes behind the scenes, so you don't need to draw the fields. This is all based on computer knowledge behind the scenes. But the step that I think is most important is that actually we can go in and optimize beam weights. Because a lot of people say, oh, 4-field box, it's easy. What benefit does this have? But for patients who are then going to go on to brachytherapy, where they're going to get a high dose, and in fact that dose does have potential toxicity to normal tissues like the bowel and the bladder, you can see that the ability to actually optimize beam weights may be incredibly important. If we move to hypofractionation, even more so. So in this case here, with equal beam weights, APPA and the laterals, you can have a large Dmax of almost 20%. So you have 117% Dmax here. With beam optimization, again, that happens internally, you can get this down by over 10%. And if we look at 149 cases that we looked at, you can see here this is equivalence between equal weighting and optimized beam weighting within the system. We can say we almost exclusively bring that down to, on average, about 105%. So again, if we're treating 50 gray and 25 fractions, that the opportunity for 110, 120% hotspot is worrisome, but it's even more so if we're doing 30 and 5, 30 and 10, something like that, and we move to hypofractionation, where the dose per day, in fact, could be catastrophic when put in place with brachytherapy. So how does this work? So what we did is we took 150 pelvic CTs from the United States, and we had 2 gynecologic radiation oncologists review them, one in the US and one in South Africa. And the one physician found 90% of them acceptable straight out of the box. The other found 97%. And the ones they disagreed on were common, and the reason was where that superior border is. And so that was the one major disagreement, and we've adjusted for that moving forward. We went to South Africa. We built 14 CTs from their patients currently under treatment, 10 at one and 4 at the other. We hit enter, got 14 plans, and all of them were accepted by the treating physician. And this is now clinically deployed at MD Anderson. On last count, there were 24 patients where the first pass of the plan was done simply with this, and it was adjusted as needed. There were 4 patients that were adjusted there with a median isocenter adjustment of less than 1 millimeter. So again, this is being used right now and provides high quality beam optimized plans in less than 30 minutes. What about head and neck? Our goals for head and neck were high, and I think mostly I torture my physicist Lawrence because I reject a lot of the automated plans because my goal is to have plans that I think are perfect. So for this, we do require more physician interaction. So for this, I need a CT scan and patient information. We have about 10 questions. What does the patient have? What lymph node levels do you want to treat and to what dose? I then have to go in and outline only the primary tumor and the GTV for the lymph nodes. And then the magic happens in the system. And about 30 minutes later, pops out a treatment plan and documentation showing the fields and all of the DVH parameters, monitor units, and all of the quality assurance. Now what happens in the middle there? A whole lot. So it identifies the Oso center, pre-processes the CT, it contours all the normal tissues and targets, which I can then intervene and adjust if needed, makes planning structures, rings, and the like. It then does knowledge-based optimization, dose calculation, plan normalization, and performs QA as well. So one of the steps it does internally is normal tissue contouring. You can see playing in the corner now are the normal tissue contours automatically done. So it does the eyes, the brainstem, the spinal cord, the bilateral parotid glands, esophagus and lungs, and also the cochlea. It also does behind the scenes the chiasm, optic nerves, larynx as well. And you can see here that we can get very good contours of normal tissues. But of course, all of us are fairly finicky about what we accept. So if you look at multiple physicians from around the world, this is what we saw in looking at all of those. So in green are those that required no edits, yellow was minor edits, or red was considered major edits on the normal tissues. And when you look at this, you can see by far most of them were acceptable out of the box. So again, all of this is happening automatically. You don't need to spend 2 hours identifying normals. We did this in clinical practice at MD Anderson too as well. All of the patients who are simulated have these structures auto-contoured, and you can see the mean surface distance between the final contour and what was given out by the computer is all under 2 millimeters there, even in the extreme settings. Now what's interesting in data that I'm not showing is even when you have all of this and I make these edits in the 7 or 8% that are edited, if you run the plan with the unedited contours, you get the same plan. So all of us take a lot of pride in finicking and finessing a lot of things, and really clinically it's a waste of time. What about nodal contours? This again is very important, making sure that you have nodes that are contoured correctly. Most head and neck physicians spend between 2 and 6 hours contouring their cases. In this case, the only thing that was identified was the primary tumor and the nodes. In the red shaded area, you can see the high-dose CTV1, in blue the intermediate, and yellow the low. The lines around those are the PTVs, which are generous in this case per the request from our partner physicians. And all of this again happens. These are contours that would pass the boards out of the box with only the GTV identified. Looking at physician ratings with 115 patients, you can again see that the large majority, well over 80 to 90%, were perfect or within intra-physician variability. So out of the box, we can get all of the CTVs and PTVs we need with only creating a GTV contour. What happens when we get the plan? This is what the plan looks like. It comes through as a document for review with the physician, where you can see the different PTV levels. Most of these plans are for ARCs. They are remarkably similar. Most of the monitor units are within about 50 of each other, and they're not a lot of monitor units. They're all typically less than 500 for a 4-ARC plan. It does automatic checks of isocenter, the PTV, and the like, and then we can go through and see the overall plan here as well. So here in red are the targets for CTV1, blue CTV2, and yellow CTV3, and you can see the matching isodose lines here. The solid line is 100% and the dotted line is 98%. So we get excellent conformality of these plans automatically, no iterative manual intervention here. And then we create a primary DVH depiction along with a sanity check. What's our max dose here? How much gets 105? And do these meet criteria? Stringent criteria. Green means good. The yellow means take a look at this. So this is a parotid that goes over the goal of 26. Why is that? Because there's a lymph node adjacent to it. We go through all of them here. The other one was again mandible. We have disease adjacent to the mandible. So these plans all, this is how it comes out with only the GTV entered initially. But how do these plans do? MD Anderson has 9 head and neck physicians and 6 treatment planners, and all they do is head and neck. They do exceptional work. Those VMAT plans are beautiful. So what we did is we pulled about 54 patients from MD Anderson, and then we pulled about 30 patients from the RTOG website, patients who were treated on clinical trial throughout the United States, and these are actual plans that were delivered. This picture looks at high-dose PTV, contralateral parotid spinal cord, and brainstem, where here, again, the diagonal is that everything was equivalent between the auto plan and the clinical plan. So anything in green means the auto plan did better, anything in red means the clinical plan did better, and the lines here are what the goals are. So here, the auto plan did better, but the clinical plan did not meet constraints here. And here, the clinical plan did better and the auto plan did not meet constraints. So you can see here that for high-dose PTV, contralateral parotid spinal cord, and brainstem, we can see that overall having a fully dedicated head and neck team gets you slightly better plans. But truthfully, all of them are in the acceptable way. And if you take a general planning group, patients who are treated on a clinical trial looking at radiation, the auto planner beats it almost every single time. So again, this is looking at that a different way. You can see here looking at 29 clinical treatment plans. On everything in green shows that the auto plans are superior. Here, green shows the auto plans are superior compared to dedicated head and neck dosimetrists, and red means the clinical plans were superior. So that's a look at head and neck. We're now working on breast. Our goal is to do comprehensive breast planning treatment. We're focusing first on the hardest, so post-mastectomy left chest wall, with comprehensive techniques, because we might as well start with the hard one. So these are all dedicated to treating the IM nodes and the supraclav as well. So these are currently a work in progress. Right now, our biggest concern is that a lot of these cases don't actually have contours when they're clinically planned. They're based on bony landmarks and or wiring, so it's hard to do an automated system when in fact you have to create contours that don't currently exist right now. So overall, our summary is that we actually have in the last 2 years created a system that we're really excited about moving forward. Our goal is to reduce the planning burden, reduce staffing shortages, and fundamentally increase the quality and efficiency of radiation plan creation. We're working on uterine cervix, head and neck, and breast, and really fundamentally we've already rolled this out and segments of this in the United States, including auto contouring of the head and neck and auto generation of cervical cancer fields. But we have a lot more work to do. For cervix cancer, we want to fully optimize the four-field box planning and clinically deploy it. We also want to do some more elegant techniques. A lot of people are using 3D conformal therapy for this, and we want to be able to do that with increased bowel and bone marrow sparing. For head and neck, we're still working on optimization of VMAT. We're clinically deploying this, and we're developing a separate atlas for postoperative fields, which are different. And for breast cancer, we're going to continue doing this for both intact and for post-mastectomy radiation. We went to the NCI. This was part of an NCI grant that was 5 years. 2 years were to develop it and 3 years are to deploy it. We're waiting right now to hear if we got the funding for the additional 3 years, but we're hoping to deploy this in interested centers in 2018 to 2021. So if you're at all interested, please let me know. We're looking for more partners. And ultimately, this is just the beginning. We are looking to expand to pediatric GI, CNS, and lymphomas as well. So I want to thank everyone for attending, specifically to Mira and Radiating Hope. This has been quite a whirlwind 2 years culminating in today. So thank you so much for your attention.